Hello, everyone. Thank you for joining us for session 2 of It's Up to Us, Race to End HPV-Related Cancers, starting with cervical cancer. I'm Shobha Krishnan, founder and president of the Global Initiative Against HPV and Cervical Cancer, GIAC, G-I-A-H-C, and the host for these global dialogue series, leading up to Women Deliver 2023 in Kigali next week. It's so exciting. I'm pleased to be joined by Meenu Anand, Director, Global Cancer Prevention at the American Cancer Society. She will be moderating the question and answer segment for today's session. In the last session, we covered a lot of ground on the basics and how to raise awareness about the human papillomavirus, or HPV, including some of the slides that were shown by the International Papillomavirus Society, showing all the links to the different types of cancers that HPV can cause in all genders, and the unique opportunity that we now have to end cervical cancer as a public health problem. Today, we will pay more attention and delve deeper into how exactly can we end cervical cancer through HPV vaccination, screening, early treatment, including implementation, and also to talk a little more specifically and focusing on low and middle income countries. So before we do that, here are some housekeeping items. It might just be best to take a screenshot because it has some useful links here, but in summary, audience microphones are muted for smooth flow of presentations. Please feel free to enter questions in the Q&A box throughout the session. Speaker bios, handouts, webinar recording will all be posted on our website at giahc.org/WD. On the main page, you'll find a brown button which says Women Deliver 2023, and if you click on it, you'll get all the information. Ongoing discussions will take place on GIAC's Twitter platform at GIAHC, and you can email us anytime. We truly appreciate you, the audience, for sharing our interest in raising awareness about HPV and to end cervical cancer. And a big thank you to our sponsors and partners with whose help we have been able to bring you this programming. And we're also planning to continue this well after the conference has ended. So now we will play a short video which would set the stage, we hope, for today's discussions.
Cervical cancer is one of the leading causes of death of women due to cancer around the world, mainly affecting women in developing countries. We now know that cervical cancer is caused by the human papillomavirus, HPV. Currently, we have 2 ways of preventing cervical cancer. If you are a young girl, you can get vaccinated and you can get screened and properly treated when older. We want these solutions to be available in the most needed countries. As the number of new cases of cervical cancer are growing each year, current services are not having the national impact we would like on the statistics. But if each country follows the World Health Organization guidelines, the impact will be seen earlier if we ensure that all girls and women have access to vaccination, screening, and if needed, treatment. We can eliminate this cancer, saving millions of lives, because this is a completely preventable disease. Cervical cancer.
And now it is my great pleasure to welcome the first group of speakers on our first segment, which is HPV vaccine equals cancer prevention. Martha Brady is a consultant for Coalition for Adolescent Girls, and she's going to talk about, some of the key lessons they have learned from other adolescent programs and how that can be applied to HPV vaccination. Dr. Kelly Mugo, she is a principal investigator for the single-dose HPV vaccine from the Kenya Medical Research Institute, and her study is called the KENSHI study. As Dr. Barnabas was telling us at the IPVC conference, KENSHI has a nice ringtone to it, isn't it? KENSHI, can she? And today we add to it and say, yes, she can, because women deliver. So Dr. Mugo will then be followed by Natalie Varney Hopkins from the International Cancer Prevention, Cancer Research UK, and she will give us a short description of how they are involved in the HPV vaccine space. Welcome, Martha.
Thank you very much. Thank you for inviting me, Dr. Shoba, and welcome and hello to everyone. I have a few slides I'd just like to present. I think, Kat, you'll be advancing them for me. Just briefly, I am at the Coalition for Adolescent Girls. I've spent also a career at PATH and at the Population Council working in sexual and reproductive health and specifically on adolescent girls. So I just want to make a few points from the adolescent girls lens around programming. Okay, next slide, please. I wanted to just put this out there because we talk about girls, adolescent girls, as if they're just one, and it just want to really remind us of this incredible multidimensional lives of girls, right? Their daughters, their sisters, their friends, their activists, their athletes, a whole range of personalities and identities that I think we should always keep in mind when we're doing any kind of programming. Next slide, please. And again, I spent years at the Population Council, so I'm a demographer at heart. So we're always focused on definitions and diversity and demography. And I don't want to belabor this point, but I think all of you probably are well aware about the adolescent stage, developmental stage, but that there's enormous diversity within that. So WHO has defined this adolescence as 10 to 19, and they have specifically called out the VYAs, the very young adolescents, which is the age group of 10 to 14 years of age. They've made specific policy and programmatic strategies towards that. And so investing in VYAs, as they're called, in fact, I have a paper on that, and why it matters. The VYAs are often overlooked in programming because in general, overall disease burden is low among this population, right? But yet we know it's a critical life phase for shaping future health and development. And it is the time for HPV vaccination. I know we can begin HPV at age 9, but just the fact that there is this call out at from WHO and major actors in the adolescent field that they have efforts and focusing on this 10 to 14 age group. I think we need to capitalize on that for HPV vaccination programming. So, and this is just, I tried to pull together, just in the interest of time, a couple of key points that we've learned from decades of working on adolescent girls programs in health and education across a range of sectors that just sort of, highlight a few things. The importance of taking a very rights-based approach to programming, not just a technology focus, but rights-based, that whatever work we do, that we're ensuring the safety and the mental and physical well-being of girls in our programs, that the girls in the programs have trusted female mentors and confidants, and where possible, we believe in engaging girls in the program design. So if you're designing a rollout of HPV vaccination, some girls should be engaged in how they think that's going to work. And then we appreciate the power of peers and social networks and influencers. And then we also believe in embracing a multi-sectoral approach, right? That cuts across both sectors as well as within sectors. Okay, so how does this matter to HPV vaccination? And here's some strategies for HPV vaccination of adolescent girls. I'm focusing on low and middle income countries. And pardon me if people are all aware of this, but this is some of the important different kinds of strategies. Vaccine delivery in health facilities, in schools, or during outreach campaigns. Those have been the three kind of models. And there's been single age cohorts, meaning taking the age group and just vaccinating them with that, or multi-age cohorts, and having the eligibility for the HPV vaccination by grade in school rather than age per se. So those are two different kinds of strategies. And then we know that both eligible girls, in school girls, and out of school girls. And finally, another very important piece has been synergies with other programs. So for example, the deworming programs, the vitamin A supplementation programs, different kinds of child health weeks and school health programs. These are really important strategies that have been tested and tried in different countries. I can't go through all the details, and many of my colleagues, I worked at PATH, many of you might know Kathy, NDI. But so just to give you a sense of the eligible girls and the in school, we've gone through teachers and flyers and brochures. They're kind of easier to enumerate because we know where they are, and you can vaccinate at the beginning of the school year. The out of school girls are harder to reach. Some of them are already married. So that requires sort of a different approach, and it's more challenging. So yeah, so next slide, please. I'm sorry I'm going quickly, but I know I only have a few minutes here. So just this we've also found really important is the engagement of parents and guardians is critical, right? They are the kind of decision makers around girls of this age, whether to vaccinate or not. And there's always been concerns about how vaccinations impact future fertility, et cetera. So there's lots of rumors and noise and things that have to be addressed early on and sensitively with communities and with parents and religious leaders. So those are all kind of really important pieces for anyone that's going to design a HPV vaccination strategy, a country strategy. Just briefly, and then I'll hand it over to our next speaker, is opportunities, I think, for moving forward. One of the important things is we need to capitalize on the progress that has been made in childhood immunization, right? And seeing the HPV vaccination as a logical extension of the immunization, of childhood immunization, if you like. We know there's increased flexibility in dosing schedule, new vaccines in development, and happily a single dose schedule, which I believe Dr. Nelly, our next colleague, is actually going to focus on. So that's why I wanted to just end with those few points and be able to pass the baton to Dr. Nelly Mogo, who's going to talk about the single dose, correct?
Thank you. That was short and sweet. Thank you.
Thank you.
Yes, Dr. Nelly Mogo, you're next.
So good afternoon to all our colleagues in Rwanda. Oh, I'm so terribly sorry. It looks like I removed my slides from the screen. And we're losing precious minutes.
It's okay, don't worry about it.
If you want, I can share your slides. I have them up.
It's best that I do it because of the, so I can move quickly. Are they there?
There you go. Yes, yes, we see it.
Thank you very much. So to begin with, I'd really like to thank the program organizers for this, for inviting me to speak about the evidence that a single dose is effective and really discuss this issue about ending cervical cancer and HPV-associated cancers. My disclosure is that my team has research funds from the Merck investigator-initiated studies, and I'll pass the outline in the interest of time. You can just peep at it. But just, I know last week there were lots of sessions in general about HPV, but the reason I'm harping on this is just this reminder that 5% of all cancers are associated with HPV, but almost all cervical cancers are associated with HPV. And if you look on the chart on the right, it's women who carry the largest burden of HPV-associated cancers, though men still get oropharyngeal cancers and such cancers. And the issue of inequity, the inequity of burden of disease, looking at high income and low income countries, on the blue map, what you're looking at is prevalence, the amount of cervical cancer in populations. And you can see the blue, dark blue zone is mostly in low middle income countries, but mostly in East Southern Africa, West Africa. And on the right side, the red, the orange, shows you death rates. And again, the same countries carry the highest burden of disease. Now, we say that cervical cancer is the fourth most common cancer, but in 36 middle income countries, it tops as the cause of death amongst women. And this is not always nice to see, but it's a good reminder why we must really invest in prevention of this disease. When you ask most people where the cervix is, they cannot tell you because it's hidden in a woman's genitalia. And when they get this cancer, it smells terribly, it hurts really badly. They bleed, they pour blood in volumes. And it's estimated that over 900 women die every single day because of this cancer. And this is important because it's a cancer that need not happen. It's completely preventable because we know exactly what's causing it. We can pick it out early and treat it before it becomes cancer. And now we have a highly effective vaccine. And I'll be giving you the evidence that one shot of this vaccine can prevent this cancer. But we need to figure out how to deliver this at scale so that that burden of disease doesn't happen. This slide is really not part of my presentation, except to focus on that goal of 90% of girls being fully vaccinated by the age of 15. That's what the WHO elimination strategy says is required for us in the 3 pillars to be able to combat this disease. We have surmountable evidence that this vaccine works. It works very well. It's safe. A was approved and started rollout in 2006, but actually has been in research, and we have data roughly up to 20 years. So substantial volume of data. So what is WHO currently telling us about the use of vaccine? So I'll be showing you the data just now that inform this change in schedule guidelines, that you can have 1 or 2 doses at least 6 months apart, meaning it can be 6 months wider. And we just heard from the last speaker about the importance of flexibility in schedule for girls and women between the ages of 9 and 20, and older than that, 2 doses are enough. And that for immune compromised, then the schedule gets revised. So what's the challenge, and why should we even think about a different schedule? Because we have very low global coverage of HPV vaccination. And the data in 2021 was at about 15% for first dose. This went down from 19%, but this was a COVID impact. And there are even bigger challenges getting the second dose in. What would be the advantage of a single dose? We can have easier logistics for delivery. We can reduce the cost of delivery. We can increase the number of girls vaccinated. Perhaps we can expand in low middle income countries the age band of girls who get vaccinated and bring elimination closer. And perhaps maybe we can also have a nearer date where we can vaccinate boys in our region. Now, this is another map about inequity. And you see the solid green areas are the countries which have access and initiated their vaccine programs. And you see that these are the same countries with the lowest burden of disease. Now, on the other side of the map, while we have some countries, mine included Kenya and Rwanda, where the conference is happening, who initiated program, a substantial number of countries in Africa have not initiated the program. And some other estimates say that 60% of cancer, cervical cancers, occur in countries that were behind in introducing the HPV vaccine. Now, that said, I think it's important for us to always be clear that we can have success stories in Africa, that it's not that we are behind on everything. And Rwanda is such a success story where the meeting is happening. And Rwanda was an early in this program. And in 2011, they started the national program, which was a school-based program, and expanded to their high school girls, and now are back to 12-year-olds. And this chart simply tells you that by age 17, they have coverage of over 80% in their population. So what impact has this had in their population? And if you look at the first column, it's the only one I'll speak to, because it looks at what they saw in their survey. The dark gray was the survey early in the program, and the light gray is the most recent survey after they had high coverage. And were able to show an 86% reduction in vaccine target HPV types. So hooray to Rwanda. You've set the path that we need to follow. So now the question is, what is the evidence for single dose? And, can we trust this? And I'll show you very, very quickly the observational data from trials which were not designed for that, but had the data. And our Kenshi study, which was specifically designed to show this outcome. I'll not show you Doris because of time, but it looked at the antibody and immunogenicity data in young girls. So the question is, will single dose give the same level of protection as the multi-dose regimens? Will it last? And what about age bands and other geographies? So the good thing about geography, this work is happening at a wide geographical range from Asia, Africa, and the Caribbeans. So this data is from Costa Rica, from the Cervical trial, the initial trial. And what you see here is the green line is 3-dose immunogenicity. And what you see is very early, the antibodies amounts, titers, level, and parallel continuously for 11 years. And the same thing happens with the single dose. And recently, they have shown data for 18 years, which is not yet published. But when you look lower down on the table, the efficacy is not different across the dose ranges. That's what they saw. Now, in India, again, they had started a program and a substantial number of young women only received 1 dose. Some got 2, some 3, and some none. And I want you to go to the last column. This is the important one, that amongst the girls who are vaccinated, 1, 2, or 3 doses, they have not seen any HPV-driven pre-cancer lesions. So it remains highly effective across dosages. So I'll come to our own trial, which was mentioned in the introduction, the Kenshi study, and appreciating my colleagues who have made this work possible, led by Ruan Barnabas. And we'll look at the month 26 data, which is 3 years of follow-up. We were very excited when we presented this data at 18 months and showed very high efficacy. Now, Kenshi evaluated girls with nanovalent, bivalent HPV vaccines and meningococcal. And what we observe here is that the green line is the group of girls who only got the meningococcal vaccine, and the red and the blue continues to be flat. So this vaccine has remained highly effective, and you can see that that was at 98% for nanovalent across both really. And I want you to compare that to the 97% efficacy for the measles MMR vaccine, something that we know works and works very well. Then we looked at the data for nanovalent for the additional 5, making up the 7 HPV vaccine types that cause 90% of invasive cervical cancer. And here we see an efficacy of 96%. Really, really good and strong data. Then we looked at data when we excluded all the girls who had any signs of previous infection at month 6. And remember, this is prophylactic. It's a prevention vaccine, not treatment. So if the girls had not had prior HPV, then the vaccine was 100% protective from HPV 16 and 18, and literally 99% protective when we include all 7 other HPV serotypes. So we are very, very pleased with this data. This, I think the last speaker just spoke to us about the concerns and the rumors and misinformation we hear. And we followed these girls, and many of them probably didn't want to be pregnant, but you can see about 5% were pregnant. Lots and lots of pregnancies across the cohorts. And the other adverse events were equal, whether they got meningococcal or HPV. So we did not see any HPV vaccine-associated adverse or harm. Now there's hope because UNICEF is expanding access, and there'll be an additional 52 countries in this map that they're supplying the HPV vaccine. So I just borrowed this line from Susan Gallard, and it's a really good vaccine that tells us what we need to do, what we want the vaccine to do. We want the vaccine to reduce the amount of community HPV infections, to reduce HPV-driven diseases and cancer. So the vaccine will interrupt that. Once the burden goes down, then the probability that our contact will have HPV goes down, and we can make a real difference and reduce the number of women who are suffering from this disease that need not happen, and help them maintain a healthy and diseased cervix and stop this suffering. So in summary, I just want to quote these words because I've always found that they are profound from Zaida. And it's a reminder what a terrible disease cervical cancer is, and that the suffering is unnecessary. And we should take a stand and say no one needs to die from this disease simply because of where they live, because it's truly a disease of iniquity. We all need to put our hands in it. We all need to participate and move forward with this motion and global initiative to stop cervical cancer. I thank all of you for listening.
That was great. Thank you so much, Dr. Muga. So next, Natalie.
Great, thank you. Kat, you've got my slides, my couple of slides. A hard act to follow, Dr. Nilly, thank you. Great, I'll kick on because I know I haven't got too much time. So yes, I work at Cancer Research UK, and as we all know, cancer is really a global issue, and it's projected that 75% of all cancer deaths will occur in low and middle income countries by 2030. And with 44% of these deaths attributable to preventable risk factors, Cancer Research UK knows that we have a duty as a world-leading cancer organisation to utilise our knowledge of developing and advocating for life-saving cancer prevention policies here in the UK to support global progress on this. That's why we set up an international cancer prevention programme in 2015. And we focus on 2 major cancer control issues that have existing WHO global frameworks and strategies, and which are also WHO NCD best buys, that if they're implemented would save millions of lives. So we've been working on tobacco control since 2015, focusing mainly on taxation, and we've been working on the HPV vaccination since about 2019. And CR UK have chosen to prioritise these areas because we played a key role in developing the science to show the links between tobacco and cancer and HPV and cancer. And we've really driven progress in these 2 areas in the UK. It was in 1999 that analysis by our researchers revealed the link between HPV and cervical cancer and how it was much stronger than expected. And they showed that the virus accounted for almost all cases of the disease, really strengthening the case to have a vaccination programme. And as we know, cervical cancer is almost entirely preventable, and receiving the HPV vaccination in early adolescence prevents cervical cancer by protecting against HPV because the immune system reacts the most to the vaccine. And as previous speakers have said, like the cervical cancer really reflects global inequities unlike anything else. And even Dr. Tedros at WHO has articulated this. And sadly, 88% of cervical cancer deaths occur in low and middle income countries with a rate of 1 death every 2 minutes. And by 2050, this is thinking that it's going to be 1 death every single minute. But, you know, happy as we've all spoken about, there is a solution, and hopefully a relatively easy solution to scale, the HPV vaccine, which really is a cancer vaccine. And we should be shouting about this at every opportunity and fighting for girls all around the world to have access to it. The HPV vaccine is now routine in the UK, and last year, a long-awaited study by our scientists proved that HPV vaccination has reduced predicted cases of cervical cancer by almost 90%, which is amazing. And this is why we have prioritised our global work to focus on HPV vaccination. And as all our previous speakers have said, there are great strides at the moment that have recently been discussed. So the change in vaccine protocol from WHO SAGE with 1 dose, and that is going to be a total game changer, which we are introducing in the UK imminently as well. And the new HPV vaccines, which are going to be coming to the market, especially the Serum Institutes. So now is really the time for us to protect girls so they have a future free from cervical cancer. And I will talk really briefly about how we work. On the screen is our lovely theory of change and what we do as our programme. It's quite difficult to encapsulate what we want to do in one nice slide, but that kind of hopefully says what we do on the tin. And we work with NGOs and research institutes around the world to really grow the policy evidence base that can be used to advocate for regional, national or local change that really helps prevent cancer incidence. We always work in partnership with groups. We don't conduct policy research or advocacy at the country level ourselves. We really want to support and enable locally led solutions with country experts, because how can I or our team sit here in London and say this solution works for you? That's really not applicable. We really look to support the most impactful policy research and advocacy where we can, and we do this by spending a lot of time scoping who we should work with and which countries we should work with within the time constraints and with a very small team. We are only a team of 3 here at CR UK who work on this. And a couple of examples who we're working with kind of currently, we're working with Selena Health in Nigeria to really help generate the evidence used to engage in, especially with the national launch of, the 15-state launch of the vaccination programme in Nigeria. And then we're also working with the Daffodil Centre at the University of Sydney and IARC, and they are going to be on the 17th of November launching the Cervical Cancer Elimination Planning Tool, which will really help 78 low and middle income countries with robust data to design, plan and fund HPV vaccination strategies and programmes. And we're also co-chairing Cervical Cancer Action for Elimination with ACS, who Minu is here chairing today, and that is for a network of organisations working together to accelerate global progress towards a world free from cervical cancer. And one thing I'd really love to take away, I don't know how many people kind of new to cervical cancer and HPV vaccine, is that a cancer vaccine does exist. Most of when we talk about cancer, the cancer vaccine, it's something that we're striving for. We do have one that already exists for cervical cancer, and we really should be advocating for our governments to offer this for free and helping girls and their families to demand it so they have access for it. So yeah, that's that from me. Really passionate about vaccination. So yeah.
Thank you. Thank you so much to this group. What an abundance of useful information. And I'm sure the audience absolutely appreciate that. So now we will move on to the next segment of our session. And this will be on advances in screening and treatment of early cervical cancer, achieving equity through technology. And we have two groups here. The first group is from the Clinton Access Initiative, and of course, as CHI, as we all know it. And there are three speakers in this group. We will start with Karen Milch Hariharan, who is the Senior Director, Global Nutrition and Cervical Cancer, followed by Dr. Brenda Katira, Country Director for CHI Rwanda, and Nangandu Chizuka, Program Manager, CHI Rwanda. Welcome, CHI Group.
Thanks so much, Dr. Krishnan. Go ahead and pull up my slides.
There is some echo, Karen, for some reason.
Are you still getting an echo?
Yeah, there's still an echo. Maybe you are all logged in twice or something. That's happened to me before.
Yeah.
She says
Is it
mute
better now?
phones. She says mute phones to eliminate echo, she says. Okay, let's mute our phone.
Okay, how about now?
It's still there, but keep going. Let's see.
Okay. Thank you. It's a pleasure to be part of this series today.
Yeah, I think we are still having problems. Karen, we won't be able to understand you. So is your phone muted?
I'm not on my phone.
Okay, all right. Kat, do you have any suggestions?
Do you have any headphones or earbuds nearby that you
Earpiece like
quickly
I'm
plug
wearing
in?
would be helpful. Do you, by any chance, Candy?
Not that would connect to my computer.
Okay. Okay, we'll do the best we can then. Go ahead, please.
Perhaps my colleague Nangandu Chizuka could go ahead and start with the focus on Rwanda, and I'll go ahead and dial back in and see if we can get a better quality.
Okay, very good. Thank you. So Nangandu, we are waiting for you.
Thank you very much. So I'm just going to share our program experience in Rwanda. So with support from United's investment, Rwanda has been supporting the Ministry of Health to implement a national cervical cancer screening program. So what's different about this is expansion of cervical cancer screening and treatment with thermal ablation to health centers. So this is getting it closer into the primary healthcare system. The previous program was based at district hospitals, but with this program, we saw expansion of cervical cancer screening services into health centers. And the process we undertook to set up this program was training of healthcare workers using a revised national curriculum, which included screening with HPV tests and treatment with thermal ablation from the previous colposcopy. Sorry, from the previous thermocoagulators. So through this program, we've been able to screen 95,000 women. 73,000 of those women were screened using HPV tests and the rest with VIA only. And the program covered 5 districts, although the government has been able to expand this to another 14 districts. So we're currently standing at 19 districts in the country. And 50% of the facilities in the country, so this is district hospitals and health centers, have been supported and equipped with thermal ablation devices, so women can actually get treated without any referrals unless they need a LEAP. 83% of the women had suspected cancer and were referred, and these actually did attend the referral. So for us, that is a win because we are certain that women got the care that they need. And this is one of the areas that has been very critical for the program to ensure that these referrals are successful. So in order to be able to achieve this, we have set up a patient tracking system, which is supported by an electronic patient tracking tool and patient navigators at the referral site. So this is what has contributed to us being able to achieve this 83% in follow-up care for women who are referred for suspected cancer. And with treatment rates for women who have who screen positive, with women who have cervical cancer lesions eligible for thermal ablation and eligible for LEAP, we've been able to treat 98% of the women. This is within the program that is supported by United. And all together, we have over 300 health facilities that are currently screening and treating. So that's in 19 out of 30 districts in the country. The next slide, please. So with looking at the different pillars that we're using to achieve this mammoth task of screening and treating women in the country, we have had the screening and treatment integrated into programs like HIV clinics and family planning clinics. So when women attend these services, they are also offered screening. And expansion of HPV testing, which required us setting up sample referral systems and establishing platforms that could be used for testing using the HPV. And then we've also invested in demand generation to address all the myths and barriers to uptake of services. And this is being driven by community health workers through various means, like media, door-to-door, and screening campaigns held periodically in the different districts. So the country is set to reach the 70% as prescribed in the elimination target. And the coverage as at the end of 2022, in the United supported project sites, we were at 41%. And in the country as a whole, we are 21%. Next slide. So this map just shows expansion of the services from 2019 to date. So there was a screening program in the sites that are highlighted color-coded blue, and then from 2019 to the end of 2022, we were able to cover more districts, meaning more women can access screening and treatment services as close to their homes as possible. So as I mentioned earlier, we do have screening and treatment in these health centers, owing to the training that the healthcare providers received and a very stringent follow-up mechanism, which utilizes an electronic patient tracking tool, which serves as a follow-up mechanism and also reports into the health information system. The next slide. So this is the projected coverage that we have in Rwanda. So the Ministry of Health has set these targets for each year in order to be able to reach 70% national coverage by 2030, but we're looking at reaching the 70% by 2027 through the strategies that we have put in place, such as the testing, diagnostic aids, and palliative care to assist women with the financial burdens to attend to treatment sites. That's for the women with confirmed cancers. And with demand generation, I think some of the new things that have come on are couple counseling, because that was one of the barriers to uptake of treatment for those that screen positive. So the couple counseling has really been instrumental in enhancing treatment coverage for women that screen positive. And of course, the patient tracking to ensure that all women who screen positive receive the treatment that is needed, and that we reduce on loss to follow-up among women who screen positive. Next slide. And from the work that has been done in the different countries where supported by UNITAID within CHAI, we have a number of publications and resources. So if you would like further information on the program that is supported by UNITAID, you may look up these resources to get more insights into the approaches and successes of the program that is being implemented by CHAI. Next slide.
Thanks so much, Nana, for stepping in there. Can I ask if my audio is any better now?
Yes.
Oh,
it
yes,
is.
great. Thank you.
Excellent. Thanks for your patience, and thanks, Nana, for stepping in. I apologize for the glitch there. But I think I really appreciate and celebrate the work that's been happening in Rwanda. And I think it's great to spotlight that, especially with the Women Deliver conference happening in Rwanda, really to see the work that's been done to put Rwanda on a pathway towards national coverage. So that's very exciting. Let me go ahead and go back to the initial set of slides. So I'd like to appreciate the role that UNITAID has played in funding the work that we've been able to do as the Clinton Health Access Initiative. We have no conflicts of interest to declare. Briefly, I'd like to highlight just an overall view of what we've been working on at CHAI, very much in collaboration with our partner governments over these last few years to prove out the tools and delivery models that can take us towards national coverage for screening and treatment services for pre-cancer. My colleagues earlier in the presentation did an excellent job highlighting the inequities across the globe, which drive the burden of disease of cervical cancer, with 90% of the more than 300,000 annual cases occurring in LMICs. And as we know, this is entirely preventable. And the World Health Organization a few years ago now launched a call to action to eliminate cervical cancer as a public health problem. And in response to that, UNITAID has invested nearly $70 million to advance an effective package of tools and delivery models to support secondary prevention across LMICs. The CHAI project has been operating across 10 countries, and our partners with the Success project, which is also supported by UNITAID, has been operating in an additional 4 countries. And our work has really been focused on expanding access to the tools and delivery models that can form the backbone for the expansion in screening and treatment services to reach 70% coverage and achieve elimination. We've taken a very integrated approach to bringing these services into the public health system, from demand generation all the way through treatment and follow-up care, targeting both women in the general population as well as women living with HIV. We've used a range of delivery approaches to reach women, including working within facilities, working at the community level,
as well as doing campaigns to share information about HPV and the importance of screening. We've worked with a range of different screening and treatment tools. And I'll highlight a few of the newer tools that we've been using here because they've really been critical to expanding access. And then I do want to highlight that the follow-up care is really critical in terms of making sure that women have referrals where needed when invasive cancer is suspected, that they're getting referrals for the appropriate treatment modality, and that they're actually coming through to follow-up appointments to make sure that the cervical precancer has in fact been treated, and if they triage negative, that they're coming back for those follow-ups to make sure that the HPV infection hasn't progressed. So really this full continuum of care is critical to ensuring that women receive a high quality screening and treatment service. The particular innovations that we've been working to introduce with our partner governments have been HPV testing for screening, self-sampling for HPV testing, which has been really popular, and then thermal ablation for treatment. And I'd like to highlight that across these different tools, it's really critical to have the right systems in place to make sure that these tools are used in a way that actually ensures that women receive high quality screening and that those who screen positive receive treatment. I would highlight that when we launched this program a few years ago, we saw a baseline treatment rate of only 50% of screen positive women, which of course is far below what we'd like to see. And so we've been able to work through partners to now reach treatment levels of 85%, largely thanks to the deployment of the thermal ablation devices. It's really critical to have these supportive systems in place to make sure that that treatment is happening. So having strong patient navigation systems, Nana highlighted the electronic patient navigation system we've helped introduce in Rwanda, having strong systems for training, mentorship, and supervision of health workers, and then having a strong community engagement and demand generation component. I'd like to highlight a few of the lessons around these tools. First, for HPV testing, the key things to pay attention to are sample collection, lab system workflow, and results return, and really making sure that we have the technical capacity on the ground to run these systems, and then make sure that women are getting their results, that they're coming back for triage where that's indicated, and then getting treatment as appropriate is really key. HPV testing is entirely feasible. It is possible to do it, to integrate it on existing platforms. You just need careful attention to these technical considerations to make sure that it's done in a quality way. And finally, rolling out thermal ablation devices has been a really clear win from the project. We've been able to expand access to treatment by rolling out more than 5,500 thermal ablation devices with the funding from Unitaid across now 27 countries in total. We've seen a dramatic improvement in the rate of treatment of screen-positive women. And the thermal ablation devices are very well accepted at all levels among health workers as well as women. So I'd like to end with really a call to action. We have the tools that we need to scale up screening. We have proven delivery models across a range of country contexts. And it's really time to take these services to scale to ensure that we can reach all women and hit the WHO targets for elimination. Thanks so much.
Thank you. Thank you, Karen, and thank you, Nangandu. Really appreciate it for all the practical tips. And also, the fact that this conference is happening in Rwanda, it has so much more relevance, and we look forward to seeing many of you there. I think it will be really wonderful. And I'm just as proud that GAIAC was a part of the Rwandan success story in the initial stages. So congratulations to all of you. And if I may ask panelists, we are getting some excellent questions in the Q&A box. Please go ahead and start answering them as you're most comfortable with. And then at the end, Minu and I will try to summarize as much as possible. I think that way we'll get to as many as possible. So the second group in the screening and early treatment is from Cure Cervical Cancer. And while they may not be as big as CHI, boy, are they mighty. So we will start with Rebecca Lepsick, followed by Samson Boyo. Rebecca Lepsick is the Executive Director of Cure Cervical Cancer, and Samson Boyo is the Program Manager in Kenya. And they're going to expand on their point of care model for screening and early treatment in rural Kenya. Take it away, Rebecca. You are muted, I think. Yes.
There we go.
Yeah.
Thank you, Shobha. Thank you for the introduction, and thank you so much for having us join your session today, along with all of these other wonderful presenters. I'm trying to share my screen. Give me just one moment, and if this doesn't work, Kat, I'll ask you to share for me.
Sure.
Okay, can you see my screen?
Yes, we can.
Excellent. Great. So again, I'm Rebecca Lepsick. I am the Executive Director for Cure Cervical Cancer. And today, our Program Manager, Samson Boyo, and I would like to share with all of you a program that we launched about 1.5 years ago called Mobile Health for Mamas. And this is a community-based HPV testing and treatment program in Kenya. So just a brief background about our organization. Cure Cervical Cancer is a nonprofit, and we're dedicated to secondary prevention of cervical cancer, so namely focused on screening and treatment. And we have been in existence for the last 10 years. We've operated in 10 countries around the world. We've reached over 180,000 women with screening and treatment and trained over 2,300 healthcare providers. And we're very proud that in 2021, the founder of our organization, Dr. Patricia Gordon, was recognized as a top 10 CNN hero for her efforts to prevent cervical cancer around the world. So Cure Cervical Cancer's programs boil down to 3 key components, and these are testing, treating, and linking. As an organization, we have pivoted fully to HPV testing as our primary testing method. And we want to ensure that all women who screen positive for HPV have access to treatment. So we're bringing treatment either through mobile clinics coming directly into the community, or through trained healthcare providers at locally based healthcare facilities. And finally, we are linking women with higher levels of care, if necessary, through our patient navigation services. So we started Mobile Health for Mamas out of an idea that we wanted to transcend some of the barriers that are preventing women from accessing care. And we wanted to bring HPV testing, particularly, directly into the community. So what you're looking at in this picture is our very first mobile laboratory. And you can see on the inside here, this is our lab technologist, Adriano, who is processing HPV samples inside of the laboratory. So Mobile Health for Mamas has capacity to take different approaches to community-based testing and treatment. One of those approaches is to bring the test directly to women's doorsteps, to collect their self-samples, and then to invite them to either mobile clinics or local healthcare facilities for treatment. Another approach that we have taken is to actually bring our mobile laboratory into the community and offer testing with results and treatment all in the same day or in a single visit. And that's the approach that we're going to share with you in just a minute here when I hand off to Samson. I would like to point out that with using HPV testing, we have reached a significant amount of women. In the last year, we've reached over 16,000 women. And we've also had a high success rate of treating those women who have precancer or are presenting with high-risk HPV. So Samson Boyo is our program manager, and I will pass the baton to Samson to tell you about our community-based mobile clinic model.
Yeah, thank you so much, Rebecca, and welcome, audience. As shown in this slide, I will walk you through our community-based single visit HPV testing and treatment model, from registration all the way to treatment and referral. We work very closely with the local government through a collaborative framework to deliver this intervention right in the heart of the community, as you can see in this slide. Next slide, please. Yes, we begin by registering healthy women between the ages of 30 to 49 as per the WHO guidelines. Here we record clients' biodata and we also take their cervical cancer screening history. Next slide. So after registration, our trained nurses, as you can see on the photos, take the clients through a short education on HPV testing and treatment, focusing on eligibility to test for HPV. They also show them how to draw a self-collected sample, and finally, what to expect from the different HPV result outcomes. Next slide. So each client will then be provided with a sample collection brush and tube, as you can see again on the photo. They are then directed to the private pods, shown again on the photo, to just be able to draw their own, rather self-collect their samples, as our presenters from CHAI has also mentioned. This self-collection process really is quick and painless, as we only aim for the vaginal swab. And then our nurses will deliver the collected samples to our waiting mobile laboratory for processing. At our mobile laboratory, it takes a maximum of 90 minutes to process 94 samples. And as we process these samples, clients are engaged in further health talks led by our trained nurses. And in some cases, we also enjoy some songs and dances as we wait for our results to be processed. This PCR machine is a Tila Biosystems PCR machine, and it has capacity to detect 13 high-risk HPV genotypes, and it also uses solar to power it, so it's very, very convenient for us. Results are then given to each individual client, and we focus our attention to HPV-positive clients who are directed to our mobile clinic. Next slide, please. Now, in the mobile clinic, all HPV-positive clients will be screened for eligibility for treatment using the visual inspection with acetic acid, otherwise known as VIA. And for those found with lesions below 75%, will be treated on site using the thermal ablation, as shown on the photo as well. And for those with large lesions and suspicious for cancer, we link them for advanced care, such as lip and also biopsy processing. Next slide. Yeah, to ensure successful linkage to our advanced for advanced care, we have a dedicated client navigator, Millicent, who is a trained social worker, seen here on the left of the photos. And she works very closely with the clients to book appointments to their referral site and ensure the clients make it to their appointments. We have clients facing, common barriers such as lack of transport, lack of national health insurance cover, and among many other barriers. In our program, we leverage what we call a social economic assessment tool to just help us determine the level and the type of support that our clients would require to ensure that they reach their appointment referral. And in some cases, CCC, we cover some of these costs to ensure that the continuum of care is adhered to. Next slide. Yes, Rebecca mentioned that we are a community-based program, and so we've had some challenges. One of them being, some of them being, combating myths and misconceptions, stigma, and in some cases we've had lack of men supporting their women through the testing and treatment. What we've been able to do really is to work very closely with the government, the local government. We've trained a pool of CHVs, as you can see in these photos. And as well, so the CHVs, what happens is that then they help us to deliver, sensitization, to educate the masses, as well as create more awareness in the community. We also engage key community leaders to ensure that we address these challenges. In the next slide, in this slide, really, we are looking at some of our 3 factors that really contributed to our success, one of them being community-based. By going to the community, we are able to reach and provide preventative interventions to the women who really need it the most. On healthcare system strengthening, we continue to train and upskill healthcare workers drawn from the local public facilities to support these interventions now and also in the future. As Rebecca has mentioned, we've trained over 1,500 so far within the year. And lastly, our innovative mobile laboratory and treatment clinics has provided opportunity to deliver the gold standard intervention right in the rural communities. Thank you so much. We invite you to interact with us more. We know we've not shown a lot of numbers and figures in this presentation, but feel free to interact with us in our handle. We'll be happy to interact. Thank you so much.
Oh, thank you. Thank you to the CCC group. As you know, I'm a huge admirer of your program and really appreciate that. So what we'll do, once again, I'm requesting panelists to start answering questions. And like last time, always the best for the last. And now we have our young leader, Catherine Ross Jeffries, to tell us a little bit about what young leaders are up to. Take it away, Catherine.
Great. Okay. So let's see. So can you see my slides and everything?
Yes, yes, please.
Perfect. Okay. So hello, everyone. I am Catherine Jeffries, and today I'll discuss how GAIAC empowers young leaders from around the world and ways that you or young leaders that you may know can get involved in the fight against HPV and cervical cancer. I have nothing to disclose. So a couple weeks ago, my lovely colleague Ariana talked about GAIAC and the American Medical Women's Association cervical cancer elimination efforts. She went over the Women Deliver Conference in 2019, where one of our middle school young leaders made a flyer for the Walk for Cervical Cancer campaign hosted in New York City. Ariana also talked about how one of our high school young leaders debuted her dance for a charity event in Tucson, Arizona, in honor of Cervical Cancer Awareness Month. She also discussed our awareness campaign for International HPV Awareness Day, Us versus HPV Prevention Week, which I'll talk a little bit more about. And she played the catchy GAIAC cervical cancer theme song jingle for you. So today I'll be going in a little bit more depth about our different young leaders committees and programs and how you can get involved. So I'll start with the outreach committee. That's my committee. And we reach out to community organizations and schools to enhance awareness and knowledge of topics related to HPV and cervical cancer. We reach all educational levels. So we primarily have a focus of at undergraduate and the graduate student level. I recently did a presentation at the Brooklyn College Cancer Center. I just want to share the flyer because it's so adorable. So these presentations are really fun for the young leaders and also the people that attend. So here's a general outline of the format of our presentations. And we usually try to play the Lady Gaga video. So if you haven't heard of her, Michelle Fraser Baldwin was diagnosed with cervical cancer. And with only a few months left to live, she paddleboarded 700 miles down the Ganges River to bring awareness to the issue of cervical cancer. It's an incredible story. If you haven't watched the video or if you haven't heard about her, you can go to our website and access the video. I highly recommend it. So the scientific committee is largely responsible for Us versus HPV Week, which is every year during the last week of January. So Us versus HPV Week discusses the importance of addressing disparities in HPV and cervical cancer, innovations and solutions in the global prevention of cervical cancer. And we try to provide new information on non-gynecological HPV-related cancers. And we do this every year in partnership with AMWA. And there are tons of opportunities for volunteers to get involved, from social media, graphic design, video editing, you name it. Additionally, we try to highlight our young leaders that are making an impact in the space of HPV prevention. So this year in January, we highlighted some of the young leaders at Women Deliver: Ibinya Nije from Cameroon, Hafsa Muhid from Sri Lanka, and Alabode Akiran from Nigeria. And they do a lot of fantastic work at the grassroots level, including the creation of digital platforms to promote sexual education, advocacy for reproductive health rights, and the creation of programs that promote health literacy. And if you're interested in watching their presentations, we can put the link in the chat for you, and I have the link right here below. So GAIAC has been really busy, and we recently created the Young Leaders Grant Program. So this grant is to exclusively support young leaders interested in eliminating HPV and cervical cancer through vaccination, screening, awareness, and early treatment. So our first application cycle was in 2022, and we've received both international and national applications, so we're very excited about that. And the first recipient was Serena Jivraj, and she is a medical student at Texas Christian University. And her project was examining the rates of HPV vaccination in North Texas. We also have a fundraising committee, and the fundraising committee has been busy with several fundraisers. Our young leaders started a water race fundraiser in conjunction with Her Health EQ to raise money to pay for colposcopes to be sent to Costa Rica. And for those that don't know, colposcopes are devices that are used to examine the cervix for cancer. And Her Health EQ is a wonderful organization dedicated to creating health equity for women. Also, AMWA and GAIAC are currently raising funds to provide speculum kits for cervical cancer screening for women in Kenya. So as you can see, there are many opportunities to get involved as the young leader in the HPV and cervical cancer prevention space, just in GAIAC alone. And we welcome you with open arms always. So if you're interested in becoming a cervical cancer champion with GAIAC, you can visit our website, or you can scan the QR code on the screen. Here's our social media handles so you can get in contact with us. Thank you for listening, and I hope to hear from some of you real soon.
Thank you, Kat. That was excellent. And thank you for your hard work. And thank you for all the young leaders who have so much passion and dedication, put so much of your energy towards this cause. Really, really appreciate it. So now we will move on to the question and answer segment that will be moderated by Minu Anand. And because this is such an important session with such wonderful speakers, we are going to go about 5 to 7 minutes over on the Q&A session, but we will be recording it till the end and we will upload it very quickly onto our website so that if someone has to leave a little bit sooner, you'll still be able to catch it. Over to you, Minu.
Thank you, Shobha. Once again, thank you to all the presenters. And Shobha has mentioned highly informational and inspiring talks, I have to say. So thanks again, it's been a pleasure. So a lot of questions are being answered already by the panelists, but I may request some of these answers to be just said live as well, if you would allow me to do that, because they may be helpful. And I'm going to start with the key issue that most countries face when trying to sustain or introduce the vaccination and screening program. And that is, and I think that question has come from one of our presenters, on countering misinformation and ignorance about sort of benefits of vaccination, benefits of screening. So I would request maybe Martha, for you to start the conversation and invite other panelists to weigh in, because that continues to be a key barrier in most countries. So over to you, Martha.
Yes, thank you. And thank you for the question. And you hit a really important question. And we have a challenge faced for a long time, right? When it comes to the introduction, actually to any new technology, but vaccines in particular, there's a lot of myths and mythologies around that at community level. So a couple of things that we know that have been helpful is before you roll out any vaccination campaign or start going, you actually have to engage community-based organizations and groups and get the parents and guardians in the loop early on. If it starts without them, that will never go well, basically. And one of the things I mentioned before, which I think is really important, is that if we can see the HPV vaccination as part of a kind of a continuation or a logical extension of childhood immunization, because child immunization programs around the world have been basically pretty good. It's one of the public health winners, right? With dips in different places. But, you know, so that if it doesn't get set up as a separate, very different thing, or I think that it may be more palatable in some settings to say, you know, this is your next vaccination for your child. It's the HPV vaccine, not get it too embroiled in other things, I think is an important potential strategy. And the immunization folks, the vaccinators are come out of the EPI program, the expanded program of immunization, right? So those are the same people that theoretically could do the HPV vaccination. So that's just one strategy, but I think there's, you know, it's a long-standing challenge, I'm afraid. And I think probably COVID has introduced another layer of complexity about how people understand vaccination in general. So those are my few points, but I'd love to hear others' comments or thoughts.
Agreed. Dr. Mugo, Natalie, anybody else, any other panelists have any comments on that?
Sorry, I really love what Martha's just said about engagement and participation. And I think it's part of respect. You know, we talk a lot about respectful communication and engagement with communities. And then when we don't involve them and inform them, we wonder why we have this wonderful thing they're not taking up, which imputes that they lack wisdom. And that is not true. I think we must evaluate ourselves on what it is that we need to do better and where we are failing. Because almost all parents that I know, and that would be as much HPV causing cervical cancer, want to do right by their child. So when that's not happening, we are the ones who are not doing it right. And I think that very quickly, because I think we need to move faster, is I recognize in our own institutions, there's a lack of adequate funding for programs to do this communication. And we say communication like it's gonna be cheap and easy, but it costs. It needs to be a costed resource that's invested in. So we have philanthropists who will finance, we will give equipment, we will give the vaccine, but this really soft, important thing is left hanging and undone. And we wonder why we're not achieving the goals that we need to.
Very well said. Absolutely. I think planning needs to be a part of introduction and a very important and key attribute of it, and should be funded and funded well throughout the program, not just prior to the introduction, but during the program as well. I completely agree. Thank you, Martha. Thank you, Nellie. Just looking at the time, and now I'm going to move on to our screening panel at this point and see if I can at least pose one or two questions here, because there are many that have come up. So quick question with regards to the WHO recommended model for treatment and best practice. What in your experience should be the key decision criteria, and how would contextual attribute play any, should be accounted for in the decision making? And I'm talking here about, you know, screen and treat, screen, triage and treat. So let me ask that question, and there are multiple follow-up questions with Rwanda work as well. So I'm going to stop here and see if I can have a panelist answer that question. Maybe start with you, Karen, and bring in others.
Sure, I'm happy to share my thoughts and would welcome Nana to weigh in as well. I think we need to recognize that funding continues to be a major constraint to buying enough HPV tests to reach women in LMICs. And that's a challenge that many of us are facing in trying to reach coverage levels. And so there's a very practical question about which of the WHO models is feasible in a given country context. And that's why for us, we have been rolling out HPV. We're trying to use HPV as much as possible as the preferred screening modality. But we do continue to use VIA as a primary screen, as well as for triage where it's indicated, because the reality is right now that we can't reach as many women as we'd like to with HPV tests. And so we've been very pragmatic about it. And I think that will continue to be the reality for the foreseeable future. As countries really aim to reach coverage, I think we'll continue to see a combination of both HPV as primary screening and VIA as primary screening. So that's my 2 cents on it. Would welcome thoughts from other panelists as well.
Comments from any other panelists?
Hello. I would just like to add that, as Karen has mentioned, the funding is a critical is critical in decision making, but also what we have experienced in Rwanda is getting to understand the different characteristics of the women that are being screened. Like, for instance, for HIV positive, for women living with HIV, you want to make sure that you try as much as possible to prevent those lesions from developing into cervical cancer. So for that group, we have gone for a see and treat, where regardless of their triage result, they get treated. But of course, you also look at other groups like the female sex workers. They will not want to undergo the treatment and abstain for the 6 weeks because it affects their income. So you look at that group and find what's the best way of screening and treating them. Will a triage and treat work, or more regular screening for them? So you look at what you're seeing in your screening program. Definitely getting feedback from the screening program is also critical to making decisions around the type of screening. Like feedback on women not wanting to have the speculum inserted. So that's one of the reasons why for the HPV program in Rwanda, it's 90% self-sampling and only 10% provider-collected samples. So these are some of the things that have led to the decisions in the type of screening that is being done. Thank you.
Excellent points. Thank you. So I think you already mentioned sort of the challenge, as you've all mentioned, to loss to follow-up. Rwanda provides an excellent story and case study for addressing that. However, it does have some very key components that may or may not exist in other countries. So to that end, I would love for others to weigh in to see what are other ways that you have seen, any strategies, messaging in particular, in terms of especially those who are positive yet are asymptomatic. How do you convey or convince them of the benefits of going to that next step?
Menu, if I can chime in on this one. Yeah, thank you so much. I think one of the ways, those strategies that we have used and we've seen a bit of good outcomes is the use of videos. You know, like you play a short clip, a 5-minute clip to the clients at the mobilization point before the collection of the samples, and this way it serves two purposes. So one of it is just to show how we are going to collect those samples to ensure that we don't have failed samples, but most importantly is to say if you turn positive, it does not mean you have cervical cancer, but it is, there are solutions to that and what those solutions really are. So I think it's just to address the anxiety and also to address the, giving these women opportunity to have enough awareness and education around HPV and the relation to cervical cancer. We've seen that work. And of course, just having more champions in the community. One of our ways is using this community health workers. They've done an amazing job for us in terms of just, having a very targeted approach in terms of relaying this information to the household level of the target group. So I think just leveraging on trained healthcare workers as well as leveraging on technology such as the videos really goes a long way in ensuring that women who will turn positive will come back for either triage or treatment. Thank you.
Great points. Thank you very much, Samson. I'm looking at the time. It's 10:19. There are still many questions. Most of them have been answered, but I have many questions that I would love to ask as well. But I'm going to stop right here and hand it back to Shobha to close the session out. Thanks again.
Thank you. Thank you so much for a well-moderated session, Minu. This is what we'll do. We are going to send a list of all the question and answers to the panelists. So if you want to answer it, please do. And if you can return in about 3-4 days, we will compile it, and we will go ahead and post it on our webpage next to the recording so that everyone has that handy as well. So we will do that later today or tomorrow. You all will get the list. And one question I have, which Dr. Mugo said she was going to answer live, is from Dr. Ibtihal Fadil from the MENA region. She says, would like to hear from speakers' view on the WHO elimination rate for cervical cancer, 4 per 100,000, the implication for countries with existing rate below 4. Wow, how lucky.
Yes, yes. And you know, when you look at countries like Australia and other countries, or the Norwegian countries or the UK, they have not relaxed. They don't take this for granted, because you have another group of people coming in who need to be vaccinated. You have immigrants coming into your population. So, and they need to maintain their vaccination program. So for example, like I mentioned in Rwanda, they started with their 12-year-olds and they did the cut up to secondary school. And because now that group's been vaccinated, they can retain this age band for the continuous vaccination. But they also continue monitoring in their populations how many pre-cancer lesions that they have. So they don't take their hands off that lead. It's too early to do that. It's not over. You know, I've learned that elimination means that the disease has been quelled. It's not that it no longer exists. And as per infectious diseases, we also know they do not respect our traditional geographies, political geographies.
Exactly. That's like polio, isn't it? We thought we'd eradicated it, and all of a sudden it starts springing up in various areas. So thank you all, and truly appreciate it. So if any one of you is attending the Women Deliver conference in person, we'd love to meet you. There are going to be a couple of us over there. And in fact, there is a live session called A Future Without Cervical Cancer that's going to take place on Tuesday, July 18th from 11:30 to 1 p.m. at the Kigali local time, at the Kigali Convention Center, room MH2.2. And one of our speakers, Her Excellency First Lady, Dr. Zeynep Bagadu, who spoke last time, she's going to be moderating the session. So believe it, we will get many of our questions answered. So let's keep talking, either in person or virtually. And until then, thank you and goodbye. Bye-bye.